Welcome to today's episode of 15 with Finn, where we cover all things about the Anika Integrity Implant. I'm your host, Adam Finn, and our guest today is Dr. Alan Ng from the Orthopedic Centers of Colorado. He is a board-certified, fellowship-trained podiatric surgeon who specializes in foot and ankle reconstructive surgery and trauma, and recently served as the ACFAS president for the 25-26 term. Good afternoon, Dr. Ng, and thank you for joining me today.
Thanks, Adam. Thanks for having me.
So can you share a little bit about your background and what led you into foot and ankle?
So as a kid, I did a lot of sports. One of my mentors is Paul Stone, who's one of my previous partners, and I injured myself when I was a kid playing basketball and doing some martial arts, and he treated me as a physician, and I got to know him really well as friends of the family and kind of followed in his footsteps. And when I was in college, I spent time in his office and watched him do surgeries. And from there, I spent some time at the program here, but I ended up doing my surgical training down in Houston with Sam Mendocino, where I did my residency and fellowship, instead of doing it here in Colorado, which ended up for the better, just because it's a little more diverse. So bringing a bit different perspective and training down there, also getting involved with the other side of, of not just treating patients, but also the political side of the profession, as well as board certification. I was past president of the American Board of Foot and Ankle Surgery, 13-14, served on multiple committees, chaired committees, and same with ACFAS, where I just finished my term as president this last year. So not only, practicing medicine, practicing surgery, but also, trying to advance the art of foot and ankle surgery further. From there, from residency, fellowship to practice back here in Colorado, where I grew up and where everything started, and kind of advancing and moving forward, with trying to advance the profession academically as well as far as quality with board certification.
And what does your current surgical practice look like today, and what are your patient demographics?
So I'm in a large orthopedic group, kind of called the orthopedic super group. Been there since 2003, so 23 years here in this practice, essentially. And, my demographics started out, when I first started, I did everything trauma, elective, sports. And it's kind of evolved over the years as it become more established and busier. I'm doing more revision, reconstruction, more complex reconstruction, where I get a lot of pathology that's very difficult and a lot of revisions, whether that be soft tissue, whether it be osseous. Still do a lot of sports as well, but I guess I'm kind of known as the revision guy and kind of the reconstructive guy. But using other advanced, soft tissue augmentations and newer fixation methods and newer total joint arthroplasties is kind of what we've been kind of evolved into. I have a fellowship as well as I'm part of the residency program here.
I know that you believe highly in the role of biologics for foot and ankle repair. Can you talk about your interest in hyaluronic acid and its role that you see for soft tissue?
Sure. So looking at a lot of the literature back in the day, the first introduction I had to hyaluronic acid or researching it was Hyalofast. Well, it was prescribed by Gobi. I think he was one of the main founders of Hyalofast back in the day. And it always amazed me because cartilage reconstruction was a big part of my practice, trying to evolve and find the best way to treat these cartilage osteochondral defects. And you read up on all the literature, you do literature reviews, all you see is Hyalofast. You see the material that's in Europe, it's in Asia, it's everywhere but the United States. Here in the United States, we have some ability to use some cartilage grafts, but we never really had Hyalofast. So I looked into what it was and what the reasoning behind it. It made a lot of sense. It's a biologic scaffold that enhances the ability for the body to heal its damaged cartilage defect. And the studies and multiple cases that's been done around the world is amazing. Much higher volume, bigger cohorts than we've ever seen in the United States. So looking at those cohorts and those studies kind of piqued my interest. Looking into biologics is a big thing in my practice for primarily reconstruction purposes, whether that's an osteochondral defect, whether it's a soft tissue deficit, whether it's a way to heal a poorly vascularized tendon that's failed multiple times. So looking at hyaluronic acid in general, its anti-inflammatory effects, its biologic healing effects, it made a ton of sense. I've even had HA in my knees, right? So the anti-inflammatory purposes, healing purposes, it makes a ton of sense. And being able to utilize it in a scaffold or a biologic augment in soft tissue repairs made more sense. Now, I've used everything. I've used collagen products, I've used amnion, I've used synthetics, I've used dermal grafts, but they all were missing something, whether it's structure, whether it's biology, whether it's, absorbability, all those things they always had some fault, one or the other. When we started looking at integrity, it made more sense to me because of the fact that not only do you have biology that's resorbable, that creates a hospitable environment for healing. A lot of problems we had with other products is difficulty fixating it in place, making sure it stayed there, isolating it to the area of damage, right? Some of the other ones would be you couldn't really sew them in because they were too friable, or they became so thin and so non-existent, it's difficult to tell where you were. So it made sense, and I still use a variety of different types of synthetics as well, but the problem with synthetics is it's synthetic. Your body can reject it.
Yeah.
There's always risks of foreign body reaction, which with any type of product, you can always have a risk, but the risk is higher. So when I started looking at integrity, it made a lot of sense to me. And I started, talking with Annika and trying it out, and I've had some really good results. Decrease in edema, faster return to activity after it's healed, decrease, symptoms and pain post-surgically. So we've had some really good results. I base a lot of what I do based on doing it first, trying it out, and make sure it's a product that I think will do well in my patients or has done well in my patients before I, really start endorsing it or start looking at it more aggressively.
That's great. Admittedly, when Integrity came out, it was primarily marketed for rotator cuff repair, and that's inherent with the two sizes that we came out with, a 20 by 25 and a 25 by 30, which you had used previously. You were also part of the design team to come out with two larger sizes, a 40 by 60 and a 25 by 60.
Okay.
I know you've done, I think, about 7 of those to date. Can you talk about what applications you're using these larger sizes for and what your typical technique looks like?
Typically for larger deficit injuries, right? So Achilles tendon areas that you have an area of large tendinosis that you have to repair. You have to bridge a deficit. Long segmental tendon injuries like a peroneus brevis tendon that may be split or something, you have to anastomose. If it's been a long tear or greater than 5 centimeters, that's a lot of space. So see, with the previous sizes, we'd have to use 2 or kind of split them and inlay them with the tendon. With the bigger sizes, it gives you more advantage and more flexibility of usage. Achilles tendinosis, perfect example. I had a patient recently that had severe Achilles tendinosis. We had to lift out the damaged tissue and sew it back together, and we used Integrity on the back side of the tendon to span the whole area of damage to enhance the ability for that area to heal. And the goal with Achilles tendinosis isn't really to cure and make the tendon perfect, but you really want to decrease the amount of tendinosis or thickening of the tendon post-repair. And that's what I'm really looking for, decreasing the inflammatory cascade and allowing that tendon to heal with better collagen. And that's the goal with this, right? We want better non-scar type collagen as much as possible when we're reconstructing these tendons, reconstructing these deficits or loss of integrity for some of the like lateral ankle stabilizations, for instance. If you have really thinned out poor tissue, you want better tissue to heal in that area.
And you're typically stitching is in a place. What are you using for suture?
Use anything from 4.0, 3.0 or 4.0 monocryl. I want something that resorbs. And I'm using that and running that along the integrity, incorporating that through the tendon, through the integrity together.
And one question we get asked often, just because ORs and surgery centers are pretty efficient, how much added time does augmenting your tendons take?
5-10 minutes, if that. And it's usually just a sewing, laying it on there and then sewing it in, and incorporating that within the tendon sheath, and it's quick. A lot of the tendon augmentation products out there that we use, whether it be an amnion or dermal graft or synthetic, you're sewing it in. A lot of times you're not able to sew it in the way you want because it just doesn't hold well. And I think the handling characteristics of Integrity does make it a little easier to use.
I know there are some competitive collagen implants on the market that are quite thick, and Integrity is about 0.75 millimeters. Can you talk about how bulkiness is kind of a disadvantage in foot and ankle?
We're looking at an area, if you're looking at the lateral ankle for a perineal tendon repair, it's essentially skin, sub-Q, and then your tendons, your tendon sheath. So if you overbulk that area, whether you use a dermal graft or anything like that, that's thicker, you're going to have a lot of problems closing the sheath if you're going to close it, or you might feel prominence or pressure against the sural nerve in that area. You want something that's going to be gone in a reasonable amount of time, 2-3 months, at least to diminish the bulk there. As that's resorbing, you want that environment. I call it a pool of hyaluronic acid healing my tendon as a repair. So you want that tendon to be bathing in the HA or the HIAF in that area to improve its ability to heal. So as that's going away, it's decreasing the bulk, right? When you have some of your bigger collagen products or your dermal grafts, or you have bulk there, and that doesn't go away very quickly.
One attribute that I think people often overlook with Integrity is its ability to hold twice its weight in native fluid. I know that you've chosen previously to soak Integrity in bone marrow aspirate concentrate prior to fixation. When do you do that, and why do you choose to do that?
So I'm looking at those tissues that are biologically deficient, right? So those tissues that may have a significant amount of scarring or tendinosis, that's maybe a third-time revision tendon repair, right? So you want some biology, you want the biological environment that HIAF's going to give you, but you also want some growth factors in the area to get the area to heal more efficiently. And a lot of the ability to harvest bone marrow aspirate concentrate is a little easier now using, I use a cellulations needle, which we carry as well, and it's an easy distal tibial harvest, getting the growth factors, and then just hydrating the integrity with that. And it just gives me more biology, right? Is too much ever enough? And that's the biggest question we ask. But with the bone marrow aspirate concentrate on really bad revisions, I'll tend to soak the integrity in that.
When it comes to foot and ankle, I don't think there's ever too much biologics available.
Yeah, when things don't want to heal, they don't want to heal. So that's kind of my philosophy when I'm using these biologic products. I mean, the ability to increase the hospitable environment for healing is important. And I think if you're doing a primary repair of a tendon or even chronic longitudinal split tear, you want something that's going to enhance your ability. And enhancing the ability means improving your patient's outcome, right? So they heal faster, they are able to get back to their activities faster, their edema is decreased, and anything that pushes that in your advantage, in my opinion, is worthwhile.
Is augmentation a game time decision for you in the OR, or have you pre-planned for that based on your MRIs?
Most of them I pre-plan it. I have it there ready for me. I'll say I go in there and it's a pristine tendon with a small split tear. Am I going to throw a patch on that when it's a small tear? Probably not. But the majority ones I'm repairing are pretty bad, and I pre-plan it by having, and it lives on the shelf in my ASC as well. Hospital's harder to get on the shelf, but they bring it. But the ASC, it lives on my shelf there.
I know you've got a number of patients that are 3, 6, even more months out now from their surgery, and you talked about their, rehab going very well and return to activity has been accelerated. Are you doing any post-op rehab differently for an augmentation versus an unaugmented tendon?
So I'm going to be honest with you. A lot of times I see these patients and they're doing great. I go, oh, you're doing great. That's awesome. All right, we're going to just start your PT and get you going. And I forget that I put the integrity in. And when I look back at some of my cases, and my fellow took a peek back, goes, yeah, the patient's doing really well. I wonder what did we do different? I go, oh, wait, we augmented that one. And you don't really realize that till you start seeing these patient outcomes, and their speed to recovery is faster. And you're like, what are we changing from what we did 10 years ago, right? So I think it's the augmentation. It's creating a better healing environment for that tendon, for that ligament, for the soft tissue, whatever you're repairing. You're creating a better environment for healing and allowing the body to heal it faster. And I just don't think, we get busy. We see 30, 40, 50 patients a day, sometimes even more than that. And you're like going through, and you're like, oh, you look great. Everything looks good. You're 4 weeks out. There's no swelling, no pain. You're walking well. Why don't we just keep going to your PT and I'll see you in a month. And before you may have seen that patient like, you're still a little swollen. Why don't we keep you immobilized, keep you braced? Maybe let's hold off on PT a week or two because you're still a little puffy. And that's where you see the difference. And it's hard to remember that you did what you did on that patient until I think, why that patient? God, he's like crushing. He's doing great. What? How does this tear? What did we do? Oh, wait, we augmented it. So you forget a lot of times, and that's something that maybe we should track more. Maybe we should pay closer attention to. But it's just one of those things that when you're seeing patients, you want best patient outcomes as possible. And then when you start seeing that, you start going, no, that really worked. So I guess before I do it again. So then it just kind of builds on itself.
All right, one last question for you. I know you work with a lot of fellows. I'm curious, what advice or recommendation would you give to somebody in fellowship about augmentation and the future of augmentation?
I would probably tell them, I did surgery when they were in grade school, and we didn't really have all these cool biologic augmentations that we did in the past. And we fixed them back then, and we sewed them together, and it took a while to heal. With technology and the way things are going now, there's no reason why you shouldn't be using something to enhance patient outcomes. And enhancing patient outcomes puts you on the front line as somebody that's doing something that's advanced, right? Something that's not the same thing as the old school guys are doing. Something that will set you apart from, the guy down the street who's not doing this. And your patients talk. And if your patient talks about, having their surgery, and I did great, 3 weeks, I was back in my tennis shoes, I was doing PT, I was doing awesome, versus a guy down the I've been 3 months already, I'm still swollen. So you want to do everything in your power to improve your patient outcomes, because your patients are going to be your best referral source. So if you want to get busy, you want to have good patient outcomes, I would consider focusing on what you think is going to give you a better patient outcome. And that's kind of the way I run my practice too. Whether it's hardware, software, biologic, whatever it may be, I try to do what's best for my patients to get them back on their feet faster. And you have to keep up with what's coming out and what's new. Otherwise, you're going to get left behind.
Excellent advice. Thank you. Well, Dr. Ng, that's our time for today. I thank you again for your expertise and your continued trust in Anika and the Integrity implant.
Thanks, Adam. Appreciate it.